So we'll talk about nursing care family experiencing a pregnancy complication from a pre-existing or newly acquired illness. So this will be for your NCM 109. The topics are all focused on the complication of pregnancy, and of course, for the side of pediatrics, it will be pediatric complication. First, we'll talk about the definition of a high-risk pregnancy. When we say it is high-risk pregnancy, it is one in which concurrent disorder or pregnancy-related complication or external factor jeopardizes the health of the woman, the fetus, or both. So anything that would give the pregnancy a complication, may it be it affects the mother only or the baby only or both the mother and the child. So it could be a disorder of the mother before she get pregnant, or it could be a disorder that she developed during pregnancy or a complication that she developed after pregnancy. So we have here the nursing process related to the care of a woman with a high-risk pregnancy. So number one is assessment. When we say assessment, we have to gather the objective data. These are our vital signs. Anything that we could see, the results of blood tests, ultrasounds, vital signs are all objective data. So when we say objective, it's observable. And when we say subjective data, primarily for this case, for a high-risk pregnancy, we have to know the level of edema and exhaustion. So you might be wondering why is it that level of edema is considered subjective? Because before the patient comes into the clinic, she knows how is her edema, because edema in pregnancy is normally found in the lower extremities because of the pressure of the gravid uterus, and they have to tell you if with this edema exhaustion accompanies it. So that is a subjective data that could be coming from the mother. So the nursing diagnosis for this one is impaired tissue perfusion related to poor heart function, secondary to mitral valve prolapse during pregnancy. It could be a heart condition, or it could be pain related to pyelonephritis, secondary to uterine pressure on the ureters, because the enlarging uterus might affect, the normal physiology of the body, and fear regarding pregnancy outcomes and related chronic illnesses. So fear, when you say fear, it is something that you experience when you see something. And if it's anxiety, when we say anxiety, it is something, it is a fear of the unknown. So what is the difference again of fear and anxiety? When we say fear, when you say a snake, you say a snake. When you say anxiety, I think the snake is in the behind the door. Okay, so anxiety is a fear of the unknown. We have here, what could be the outcome? It could be based on the pattern of life. When we say the pattern of life with regards to the individuality and the uniqueness of patients, okay, because whenever we encounter patients who are suffering from maybe the same illness, okay, we could not say that their adaptation or their response to medications and treatment are the same. So you have to plan based on the condition of the patient. And you have, of course, what are these plans for the patient? And these are individualized or solely for a certain patient. It should be implemented. And of course, you have to evaluate if all your plans are being implemented or all your plans are successful. Okay. So this is a picture of a nurse taking the vital signs of a pregnant woman. So getting an objective data per se. Okay, so again, these are not so new because these are 2020 national health goals related to complications of pregnancy. But I just wanted to share that even in 2020, we already have these goals of being able to lessen the number of morbidity. When we say morbidity, it's the death. I'm sorry, morbidity, it's the illness. And when we say mortality, it's the death of the patient. It could be because in obstetrics, it could be that the mother and the child is affected. So the first topic that we will have is cardiovascular system or diseases of the cardiovascular system or cardiovascular disease. So it affects 1% of all pregnancies, but it accounts for 5% of maternal deaths, meaning is that when there are maternal deaths, it could be 5% coming from a cardiovascular disease. And because of this blood volume and cardiac output that is increasing in early pregnancy, because when you are pregnant, according to FLAG, okay, in 2022, and Pilitary for the past 8 editions of the maternal and child health nursing, okay, there is an increase of the blood volume of about 50 to 75%, particularly in your plasma during pregnancy. And this one peaks at 28 to 32 weeks, which places stress on the compromised heart, okay, or will compromise the heart of the pregnant woman. Because of course, when the blood volume increases, okay, the heart is pumping a lot of blood, and sometimes it could cause diseases to the patient. Okay, but again, that is physiologic anemia of pregnancy, but it could lead to possible complications. Okay, because of this stress that is placed on the heart of the woman. Okay, New York Heart Association criteria are commonly used to categorize the severity of a heart disease. So when you will be diagnosed, when the patient will be diagnosed of a heart disease because of pregnancy-related conditions, and then they have to pattern this with the criteria produced by the New York Heart Association. And of course, most common are valve damage caused by rheumatic fever or Kawasaki disease and congenital anomalies or coarctation of the aorta or atrial septal defect. Okay, these things will be discussed to you later on. So we have here the rheumatic heart disease and pregnancy. It actually is the most dangerous time. Okay, it is the most dangerous time is of pregnancy is um during the 28 to 32 weeks. Aside from the formation of your lung surfactants, this is also the weeks. Okay, this is also the weeks or the weeks. These are also the weeks that your blood volume peaks. Okay, so that is not a week. Okay, this is a typo error. And the estimation of whether a patient with pre-existing cardiovascular disease can complete pregnancy successfully depends on the type and extent of the disease. So, meaning is that when you have a heart disease, okay, meaning that when you are having heart disease, there could be a problem. Okay? There could be a problem on pregnancy. Okay, there could be a problem in pregnancy. Maybe, okay, maybe that the doctor will tell you you have to choose between continuing pregnancy and you have to stop some of your medications because this could complicate the baby or the growing baby inside, or you have to give up the baby to live. So there are conditions wherein the doctor lets the patient choose during this time. Okay, we also have here common topics on left-sided heart failure and of course the right-sided heart failure. When you say left-sided heart failure, this is just an introduction to this condition because we are just talking about pregnancy. So it occurs in conditions such as mitral stenosis, mitral insufficiency, and aortic coarctation, meaning this could be present before, again, the patient became pregnant. I'm sorry. So the patient might suffer from orthopnea, okay, and paroxysmal nocturnal dyspnea, or shortness of breath, or suddenly waking at night, like she felt she's drowning. Okay, so what will you do? Of course, in every diagnosis of a patient, there is always what we call as a nursing intervention. So number one, you have to have low molecular weight, or like for example your heparin. Okay, again, heparin is given because it doesn't cross the placental barrier, because if it will not cross the placental barrier, meaning it would not affect the baby that much. Okay, antidiuretics could be given, antihypertensives or beta blockers. Okay, sometimes they call it beta blockers. Okay, patient will be scheduled for non-stress test. Again, what is your non-stress test? Your non-stress test is a type of, let me annotate sometimes. Okay, when you say your non-stress test, this is a type of, let me change the color. External, this is what we call sometimes as your external fetal monitoring, external fetal monitoring, okay, external fetal monitoring with the use of your cardio topography machine or your CTG. So when you say CTG, this is your cardio tachography machine. So when you say your cardiotocography machine, it measures, okay? It measures your the cardio, the heartbeat of the baby, and the toco means the contraction of the mother. So it records the again heart rate, okay, of the baby and the contractions of the mother. So NST is actually done, okay, to know if the baby is doing well. So we are noting for the FHT versus contraction. So meaning in NST, if the baby moves, there should be an increase in the fetal heart rate of the patient of 15 beats for 15 seconds twice in 20 minutes. And we call it as your reactive NST. And when we say non-reactive NST, okay, when we say non-reactive NST, okay, when the baby moves inside the womb of the mother, there is no increase in the FHT in the cardiotocography machine, and that could be the reason of the doctor to order your contraction stress test. Okay, your contraction stress test or your oxytocin challenge test. Okay, I hope you have discussed that in your OB1. If you don't still understand it, you can find it on my videos at YouTube. And then they will also have to do the serial ultrasound to determine the placental perfusion because this is a cardiac disorder. Okay, so let's proceed to the next slide. Next is we have here the right-sided heart failure. So when we say right-sided heart failure, of course, it could be unrepaired. Okay, it could be congenital. It could be your Eiser-Menger syndrome or what you call as a right or left atrial or ventricular septal defect with accompanying pulmonary valve stenosis. But sometimes what is our problem here as nurses is the mother might not be aware that these conditions are present before pregnancy. Most specifically, if the mother is not seeking for uh, checkups, okay, at the health center. So it could cause distended liver and spleen, ascites, or enlarging of the tummy, and you have your peripheral edema. So you could observe that the edema is not only normally found in the lower extremities, but it could be in the periphery, right? So patients with uncorrected RHSF or right-sided heart failure will not be allowed to get pregnant. But if they will be still wanting to get pregnant, they may have to have a repeated ABGs, your arterial blood gases, to ensure fetal growth, and they may need a pulmonary catheter, okay, to measure particularly the pulmonary pressure. And these are all heart-related interventions. And of course, you have to have you have to extremely close monitor your patient, specifically with the use of anesthesia, okay? Because there could be a possibility of hypotension. Next is this could be an example or a picture of a left-sided versus the right-sided heart failure. It says here that the left-sided heart failure could be the most common type of heart failure, while the right-sided could be particularly on the inability of the heart to move oxygen depleted blood to the lungs to pick up new oxygen. And for the right-sided, okay, it is most often caused by left-sided heart failure. So it could be a complication really of your left-sided heart failure. And of course, this one for the left-sided, it is the inability of the body to reoxygenate blood. So it could be a great problem or a big problem. So this one, it could also occur even when the left side of the heart is apparently normal. So it could be the right-sided heart failure. It could be a complication of the left-sided, but it could be still there even in the absence of a left-sided heart failure. Okay. So this one is really are topics in the board exam. Okay, these are really topics in the board exam. So classification of heart disease, the board exam is fond of asking what are your interventions as nurses when your patients are suffering from certain classifications of your heart disease. Per class one, it is uncompromised. So there is no discomfort. Okay, there is no anginal pain. So sometimes, since there are no symptoms, the mother might not be aware that she is suffering from class 1 heart disease. For class 2, okay, it is slightly compromised. Ordinary physical activity causes excessive fatigue. Okay, so it is an ordinary physical activity that is causing the patient fatigue and palpitation, and of course, dyspnea or difficulty of breathing or anginal pain. Okay, so for class 3, it is markedly compromised. So during a less than ordinary activity, the patient might not be doing something that is heavy or something that could cause her fatigue, but the patient could feel excessive fatigue, okay, palpitations or dyspnea or anginal pain. So, what is the most when we say it is the most or the ugliest, or meaning what is the most. Oh, I'm sorry for I lost the word. Okay. So this one, what is the most severe? Classification of heart disease is this one, class 4. Even if you are not doing anything, the patient is unable to carry out any physical activity without experiencing discomfort, even at rest. So this came out in the board exam, that the board exam asked what could be the classification of heart disease that even at rest the patient will suffer from discomfort, and the answer is class 4. Okay? So next tayo. Okay, so I cannot speak Tagalog because we have our foreign students, and I should be doing this great for them. Next is we have the high-risk pregnancy. Okay, cardiovascular issues. Aside from those, you could have valve damage with or without valve replacement. You could have congenital abnormalities. You could have the CAD, or the coronary artery disease, or chronic hypertensive vascular disease, or venous thromboembolic disease, or peripartum heart disease. So you'll just have the most common. So for this one, actually this is new. The peripartum heart disease is the one that is really bothering, okay, the OB-gynecologist, because you could not imagine that um, those patients who have no previous heart disease could have this heart disease that could possibly take the life of the woman and the baby. And what is painful, the cause is unknown, but the mortality rate is 50%. In the Filipino culture, we call it 50-50. Okay, so the peripartum cardiomyopathy or the peripartum heart disease have no, the cause is unknown or idiopathic. The cause is unknown or idiopathic, but then again, we have to note that this condition could come out even in the absence of a previous heart disease, or even in the cases wherein the patient had normal vital signs during pregnancy. So it could occur in black multiparas with gestational hypertension. Later on, we will have discussions of what is gestational hypertension, how could it differ from your pregnancy-induced hypertension and hypertensive disorders in pregnancy. So we will talk about those one, the transitions that happen before we could finally call it hypertensive disorders in pregnancy. So the patient involves or develops myocardial failure, signs such as shortness of breath, okay, shortness of breath, chest pain, and the non-dependent edema and cardiomegaly. So there is also enlargement of the heart. So this could be the doctor might want to give the patient immunosuppressive therapy. And there is a typo error here. If it persists, okay, the postpartum, the woman may not be allowed, okay, may not be allowed to get pregnant, okay, may not be allowed to get pregnant. So this time you could not use oral contraceptive such as your COC, okay, the combined oral contraceptive that contains both your estrogen and progesterone. And if with another pregnancy, a patient may need a heart transplantation. Okay. So after the transplantation comes with the possibility that the patient could get pregnant, but still with risks. Okay. The risks would not be totally eliminated by with this case of heart disease. Okay. Next, high risk patient's assessment. Generally, we have to know the level of exercise, the things that the patient could do or could assume, or the presence of a cough that is not treated, or the possibility that the patient could have edema outside or aside from the edema That is normal in the lower extremities during pregnancy because, again, of the pressure of the gravid uterus. And comparison of baseline vital signs. Of course, you have what you call as okay, we'll write it on. We call it a pre-pregnant BP. So we also have what we call as pre-pregnant BP. When we say, sorry, pre-pregnant vital signs. Okay, when we say pre-pregnant vital signs, these are the vital signs of the mother before becoming pregnant, and sometimes these are our baseline when we assess these patients during pregnancy. So we have to see if there is an marked increase of this vital signs or decrease. Okay, so whatever are the possibilities, then the doctor will have to intervene. So we have to assess also the liver size. This could be a right-sided heart failure involvement. It could be a complication, and we have to let the patient have the echocardiogram. So for us to assess the health of the heart and the fetal size, we have to know if the baby is really enlarging, because we also have what we call as SGA. Later on in your pediatrics, you will know about SGA, the small for gestational age, and those baby who would be born because of preterm labor, and preterm labor could be um, in line, or it could be a reason, or it could be a complication rather of heart disease because of vasoconstriction. So there are also what we call as fetal heart rate decelerations. So when we say fetal heart rate decelerations, let me just discuss a bit. You also have what you call as early decelerations. When we say early decelerations, it could be because of head compression. It could be because of the head compression of the baby. When we say late decelerations, late decelerations, okay, when we say late decelerations, let me just, I'm sorry, okay, the color is also changing. Everything is changing. When we say late decelerations, when we say late decelerations, it could be because of utero-placental insufficiency. Okay, it could be because of utero-placental insufficiency. And when we say variable decelerations, and when we say variable decelerations, okay, when we don't forget, you have to be happy while you're viewing my videos, because with happiness and joy comes with retention. Variable deceleration is because of cord compression. It's because of cord compression. And take note that in early decelerations, in early decelerations, take note that this is normal. Okay, this is particularly normal when I will be going to draw. If this is a contraction, this is the start of the contraction, and this is the end of the contraction. In early decelerations, when the uterus begins to contract, there is a decreased FHT at the start of the contraction, and then at the end of the contraction, it normalizes. So, ibig sabihin, it means that during contractions, the head of the baby might be compressed. So that is why there is what we call as early deceleration at the start of the contraction. When we say late decelerations, okay, so this could be another contraction, the FHT decreases at the start of the contraction, and it doesn't close back to normal at the end of the contraction. It is still decreased, and this is because of uteroplacental insufficiency, and this is a medical emergency. The baby should be born immediately. For variable decelerations and for because of cord compression, in the board exam, the number one intervention with this is to change the position of the mother. When you change the position of the mother, it could be into a knee chest position. It could be into a knee chest position. It could be into a knee chest position. Okay, it could be into a knee chest position. It could be or modified T position, or the Trendelenburg position. Okay, just to remove the pressure on the cord of the mother. So when after you remove the pressure uh, of the cord of the baby, okay, of the cord of the baby, after removing the pressure on that cord, you could give oxygen to the mother. But then again, if you give oxygen to the mother would tell you, "Oh, I don't need oxygen because I can breathe." You have to explain to the mother that the oxygen is not for her, but it's for the baby, to prevent the baby to have bradycardia. Okay, pag sinabi natin, when we say bradycardia, the heartbeat of the baby is very low, And if the heartbeat of the baby is very low, it could lead to hypoxia, decreased oxygen. And when there is a decreased oxygen, the anal sphincter of the baby would open and the meconium would come out and mixed with the amniotic fluid. And then the baby will have what we call as meconium aspiration pneumonia, because meconium is the first stool of the baby and meconium should be out after the baby is born. So what happens here, if there is a variable deceleration, it could lead to meconium aspiration pneumonia. Even inside, there is already the release of the meconium, and that is deadly, okay? Next is we have here high-risk pregnancy. So what are our considerations with regards to nursing diagnosis is deficient knowledge. So this is really a problem to the mothers that we are handling in the area. In deficient knowledge meaning health educations may not be given to them or nobody have educated them regarding pregnancy outcomes. Okay, so what will you do as the nurse is to promote rest since there is fatigue, there is palpitation, there is dyspnea. Okay, you have to promote rest. And of course, promote healthy nutrition. There are diets that should be strictly promoted to the patient and educated regarding medication that if it's a maintenance, they have to take it on time. And they should not be stopping. They should not stop taking the medication until the doctor will order for them to stop. Okay, educate regarding avoidance of infection because they will be immunocompromised. So they are not allowed to go to crowd. So this one, for the intrapartum period, it is important that you have to position the mother in a position where she feels comfortable. And when there is vaginal delivery, the mother should be given epidural anesthesia because our problem here is the inability of the mother to tolerate pain. Okay. For the postpartum period, of course, you have to assess for heart failure because the patient might be having a heart failure or a heart problem for her entire life, and they will be again. You could give anticoagulant and digoxin therapy. Again, these are drugs, and this should be ordered by the doctor. We have three functions. We have the independent, dependent, and collaborative functions. When we say independent, these are the things that we could do legally within the scope of the nursing practice, even without the doctor. So you could just give hot compress, okay, health education, provided that you know what you're telling because you're handling life, okay. You could not have a mistake, right? In the nursing profession, it should be always, or even in the healthcare profession for midwives, it should be no excuses, no mistakes, because we could not give back the life of those patients who will be dead because of our negligence. Okay. So we also have what we call as dependent function. The first one was independent. The next one is dependent function. These are the things that we could only do with the order of the doctor, like giving medications and giving or infusing IV medications, okay? Or we also have what we call collaborative functions, and these are the functions that we could freely collaborate with other members of the healthcare team when we are taking care of the patient. Another one is intermittent and pneumatic compression boots. These are really the management that could be done when the patient is hospitalized because of a cardiovascular disease. Okay, so for the QSEN, it doesn't change. We should be the intervention should be patient-centered. When we say patient-centered, it could be an individualized care given to the patient. Okay, you have to take note the the uniqueness of the patient. And then for teamwork and collaboration, again, you have to work with the different members of the healthcare team abroad are really fond of using the IPC, the interprofessional care. When we say interprofessional care, a lot of healthcare professionals are taking care of a certain patient, not like in the Philippines, and that others could take care of 50 patients. Okay, but again, that is a reflection of how resilient we are. Evidence-based practice, of course, by all means, at all times, we should be implementing what we call as evidence-based practice. Okay, we should be implementing what we call as evidence-based practice, meaning these are, okay, when we say evidence-based practice, these are the most or the best intervention that we could give to the patient. So what makes an evidence-based practice? Remember these three things. When we say evidence practice, these are patient preferences or values, the things that the patient wants, like for example, position, who would know the best position for the patient so that the patient could be comfortable? It's the patient. So patient preferences really matters. Number two, the products of research or research studies. Don't tell me that it's researches. No, there's no plural for that. It's research studies. And then, of course, clinical expertise. When we say clinical expertise, these are the protocols or interventions done in the hospital that are tested to be effective. Okay, so again, what are the three scaffolding or what makes an evidence-based practice? Patient preferences. Okay, patient preferences. Number two is products of research studies, and three are these are clinical expertise. When we say QI, quality improvement, all the time, okay, all the time. So there are magnet hospitals, there are ISO certified hospitals because they wanted to assure that every intervention that we are doing is of quality. And when we say it's safety, of course, this should be our priority, the safety of our patients. Again, we could not give back the life once it's lost, okay? And then, of course, the use of technology, the AI generic, the Google Gemini, the Chat GPT, the EHR, okay? The machines that we are using in the hospital, okay? Or the technology, I should say. Another problem could be this one, the thromboembolic disease. So what will you do? Okay, so you have to, for this one, we all only want to focus on what intervention because there are a lot of cardiovascular disorders during pregnancy. Of course, because there is the possibility of pulmonary embolus, okay? Because of the poor venous return or the phlebitis or estrogen that is increased in the body or congestion, okay? So for this one, it could be a combination of stasis of blood in the lower extremities because of uterine pressure. It's because of the enlarging uterus. There is no blood stasis or the blood would stay down there. Um, it could not be moving all throughout the body. And what are the risk factors? Deep vein thrombosis, or if you are getting pregnant more than 30 years old, so what could be the possible signs? Chest pain, okay? Unexplained chest pain, or the onset of difficulty of breathing, or your dyspnea, or you cough with blood, so that is hemoptysis. And then suddenly your heart will become, you will beat fast, and then missed beats, okay, missed beats, and then dizziness or fainting. So this could be an indication or a sign of venous thromboembolic disease. What will you do? Avoid constrictive knee-high stockings, of course. No sitting with legs crossed at the knee. So you have to tell every pregnant woman in the back sitting down for a long time, do not do this. Avoid standing in one position for a long time. You could advise those pregnant clients in the mall, okay? Heparin will be given, of course, to prevent the possibility of DVT. Anemia in pregnancy. Anemia in pregnancy is also called pseudoanemia. When we say pseudoanemia, it is normal, but it could complicate pregnancy because the possible causes could be diet low in iron or heavy mens or unwise weight reducing programs. Okay, so it could be a pseudoanemia. It could be an anemia that you could not understand where it's coming from, but we also have what we call as physiologic anemia of pregnancy. When we say physiologic anemia of pregnancy, it is normal because of, again, the increase in blood volume, particularly on the plasma of 50 to 75%. Okay, so what will happen if there is anemia in pregnancy? Okay, so during the antenatal part of pregnancy, there could be poor weight gain. The mother is not gaining weight, even though if the baby is enlarging. The mother could have preterm labor or preeclampsia or increase in the blood pressure. Um, Intranatal, it could be during labor, it could be dysfunctional. The mother could have a very difficult labor that could turn to hemorrhage and shock, and of course could end to cardiac failure. And then for after pregnancy, there could be an infection, okay? Because if you are having anemia, your of course your immune system is not really working, and then there could be subinvolution. When we say subinvolution, there could be a delay in the return of the reproductive organs into their normal position, and that could be problematic. Okay, there could be a delay in the return of the reproductive organs and embolism at that. For the fetus could be premature because of preterm labor, intrauterine growth retardation, okay, because of this problem, intrauterine growth retardation, low birth weight, or poor Apgar score during delivery. So you will have to learn about Apgar scoring for the first minute and 5 minutes of life of the baby. And those are your baseline data of how the baby, how well the baby is working after birth. Depleted iron store, they could have anemia during pregnancy. And of course, they have a high prevalence of failure to thrive, okay, outside the womb of the mother. For this one, for the diabetes mellitus, pathophysiology and clinical manifestations, classifications, or gestational diabetes. So let me just give you a picture of what is diabetes during pregnancy. So when we say diabetes during pregnancy, this is what you call as your gestational diabetes, and it is due to human placental lactogen. Okay, your HPL is a hormone that is regulated during early pregnancy for the purposes of breastfeeding. But then again, okay, it's for the purposes of breastfeeding, but it has anti-insulin properties, meaning the insulin is not opening the cell for glucose to go inside the cell and for us to develop ATP, adenosine triphosphate, or energy. So what is the main cause of gestational diabetes? It's the human placental lactogen that is primarily for breastfeeding, but it has anti-insulin properties. Okay, that would cause gestational diabetes. And what is our problem with gestational diabetes is it could lead to, we'll just have to focus on board exam questions. It could lead to hyperglycemia of the mother. Hyperglycemia of the mother. Okay, so who is hyperglycemic? The mother. Okay, the baby could be hypoglycemic. Hypoglycemic. Okay, the baby could be macrosomic, larger. Okay, the baby is larger. The size is larger than the normal size of a baby that is born. Macrosomic, or the baby could be born dead, okay, or you're still birth, okay, because primarily your high blood sugar, the high blood sugar of the mother affects, okay, the high blood sugar of the mother, the high blood sugar, okay, the high blood sugar of the mother affects the formation, okay, it affects the formation of lung surfactants. It affects the formation of lung surfactants. That is why the baby could be born dead. Okay, so the most unwanted complication of your gestational diabetes is stillbirth. The baby could be born dead. That is why in early pregnancy they are doing what you call as amniocentesis, or they will get an amniotic fluid from the mother. I hope this it was tackled by your OB1. In amniocentesis, they will get the amniotic fluid from the mother, of course, and then they would test the presence of phosphatidylglycerol. This is the most important lung surfactant that you have to check if the mother is suffering from, okay, is suffering from diabetes mellitus, okay, or gestational diabetes mellitus, what you call as your phosphatidylglycerol, okay, phosphatidylglycerol, okay? Phosphatidylglycerol. So I'm just checking the spelling anyway. Phosphatidylglycerol. So we have the right spelling, phosphatidylglycerol. Okay, so that is the most important lung surfactant that you will be checking, okay, when the patient is suffering from diabetes. You just have to remember those things. Okay. This one is a pregnant patient with malaria. So if you think this is not a problem, but it is, okay? Malaria is a protozoan infection transmitted by Anopheles mosquito and mosquitoes, okay? Incubation period is 12 to 14 days, so it could be quite long. So what could be the signs? You would not know that you have malaria until there is or are elevated liver enzymes, both your AST and ALT, okay? And then you have fever, body malaise, headache, thrombocytopenia or lower platelet, and then finally, what will kill the mother, or what will increase the morbidity and mortality of the mother and the child, is the presence of the renal failure. So what will you do? Again, of course, it's basic wearing clothing that covers most of the body for you not to be bitten by a mosquito. And of course, you have to use a mosquito net and an insect repellent and keep the windows closed. And if there is an endemic, you should not be traveling to endemic areas. So this is how will you protect the mother against malaria during pregnancy. So what will you do if, for example, if the mother is affected with malaria during pregnancy? We will give your very famous drugs of or for malaria. So what we are having here are, of course, these anti-malarial drugs will be given to reduce, of course, LBW or low birth weight or preterm infants. Okay, you could give sulfadoxine or pyrimethamine, safe. This one for the third trimester, but the drug of choice is always your chloroquine. Okay, it is always your chloroquine. This is the drug of choice for malaria because it could be given in any of the trimesters, even for the first trimester that is considered the period of organogenesis or the formation of the organs of the baby, which sometimes okay, we could not just give medications because it could affect the growing baby. So what are the drugs that are teratogenic or could affect the baby or could lead to congenital abnormalities of the newborn? Take note, the quinine, atovaquone, proguanil, and tetracycline. So you could only give for safety, even in CHN, community health nursing, you should be giving chloroquine. Next, of course, the patient with UTI. Until this moment, we do not know what really is the relationship of UTI to pregnancy. But then again, there is a study who would tell us that progesterone, the hormone for pregnancy. Okay, what did I say? Progesterone, the hormone for pregnancy, it is a relaxant hormone. The first function of the progesterone is to what? To keep the baby alive. Okay, to keep the baby alive. Okay, it keeps the uterus nutritionally abundant for the baby to survive. It relaxes the uterus to prevent abortion and preterm labor, of course. That is why progesterone is the hormone for pregnancy. And of course, it could be because of urine stasis or the urine that is being confined to the bladder because you're pregnant and sometimes the bladder is displaced to the right. Okay, the minimal amount of glucose provides a medium for bacteria because sometimes pregnant patients are normally having high blood glucose because again of gestational diabetes mellitus, okay, that is normally coming from HPL, and HPL again is normally present in the body during pregnancy, okay, for breastfeeding purposes. Technically, all pregnant women are candidates have gestational diabetes mellitus. That is why when there is a possibility that your sugar is and it's increasing, then you have to seek for medical attention. It could be associated with preterm labor and PROM. This is always the justification of the book that UTI could possibly lead to preterm labor and PROM. What is PROM? Premature rupture of membranes, and it could be used caused by. Okay, sorry. It could be caused by this one, E. coli or your Escherichia coli. So what will happen? Okay, or what will you do? Okay, for UTI, for the safety, you could give Amox, ampicillins, cephalosporins. You could give sulfonamides, but not during the time that the baby is born because it could lead to hyperbilirubinemia in the newborn. And of course, tetracyclines could not be given because it could lead to congenital abnormalities of the baby, particularly bone growth retardation and staining of the teeth. Again, what is safe? Amox and ampicillins and cephalosporins. Okay, this one is lifted from the book of flag. You can see this in your book. Okay, you can find it in the. I just don't know what page this one is, but then again, what would I want to tell you about COVID-19? Even though the pandemic is over, okay, there could be some questions in the board exam that could be possibly asking if, okay, if COVID-19 vaccine could be given to pregnant women, and the answer is yes. Okay. And again, of course, COVID-19 could cause a severe respiratory cardiovascular syndrome, symptoms to the baby and to the mother. That is why, since there is a possibility of transmission, okay, since there is a possibility of transmission, then there are some protocols in the hospital that will be that were implemented during the COVID-19 pandemic. Again, what do we want to know about this discussion is COVID vaccine could be given, safely given during pregnancy, and that is on about that is uh, again written by Rasmussen et al. In 2020. How about endocrine system? So I'm sorry, this slide should be the continuation of the diabetes. It might be because of the technology that we are using. So what will you do if there is diabetes? Of course, there is screening, right? If there is diabetes, aside from gestational diabetes, you also have um another diabetes. It could be type 1 or type 2 that could aggravate the condition. So what will you do? Of course, if there is a deficient knowledge regarding this one, you have to educate them regarding diet and the importance of exercise or moving during pregnancy. And that might help them to get rid of the possibility of complications to the baby later on. Another one is therapeutic management. Of course, there could be insulin, okay, given to the patient again for maximum placental function, okay, and well-being of the baby. And health education should always be a priority during this time. And after giving birth, there is a portion of the book telling us that uh, if you had gestational diabetes, you could have DM type 2 later on for a lifetime. So you have to manage your blood glucose. Okay. So this one, of course, aside from nutrition, you have to monitor the fluid intake because this fluid intake sometimes aggravates the condition. Hygiene, of course, voiding after sexual intercourse because the bacteria could be coming from that. I'm sorry, this should be for the UTI. Again, it's lost. Sorry. At least we know that it's coming from UTI, or you could have the cranberry juice intake. Okay, so this one. Okay, so this question, which statement by a woman who is 8 weeks pregnant and has cardiac disease would you most likely to follow up closely? One, I have been really constipated for the last few weeks. B, I have gained 4 pounds during the last week, but I am not eating more than before. C, I have not felt any fetal movement as yet. Or D, I have had episodes in the morning when I have almost thrown up. So your answer should be dun, 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 dun. D. Okay, so the rationale is there. It's constipation and nausea are common during the first trimester. Fetal movement or quickening is not usually found this time. And then, of course, weight gain of 4 pounds within a week during the first 8 weeks without additional intake could signal an increased circulatory fluid and impending heart failure. Okay. Another question is, what is the most accurate statement regarding exercise and nutrition during pregnancy for a woman with diabetes? Letter A, extreme exercise may cause hypoglycemia, therefore it should be avoided. B, during the last trimester, caloric intake should be decreased to less than 1/8 calories to control fetal weight gain. Or C, exercise reduces the need for insulin, therefore beginning an exercise regimen during pregnancy is recommended. Or D, ideally, dietary calorie intake should be approximately 20% from protein, 40% and to 50% from carbohydrates, and up to 30% from fats. And your answer should be letter D. Ideally, dietary calorie intake should be approximately 20% from protein, 40 to 50% from carbo, and 30% from fats. And these are allowing for good glycemic control. Okay. Number 3, which is the most accurate and reliable outcome measure for evaluating an intervention? Letter A, a fasting glucose of 85 mg per dl, an oral intake measurement of 720 ml of fluids within 8 hours. Or C, an exercise diary indicating the pregnant woman walked 30 minutes every day for a week. Or D, the statement by a pregnant woman, I understand why folic acid is important for red blood cell formation. Okay, your answer should be a fasting glucose level of 85 milligrams per dl. So this one for the rational, fasting glucose level is the only measure of an outcome, and the other 3 choices are evaluation of activities or processes which may or may not result in a desired outcome. So for tonight, we have discussed a high-risk pregnancy, particularly focusing on cardiovascular disorders, um, um, a glimpse of what is gestational diabetes mellitus, anemia, and of course, malaria and UTI during pregnancy. So you have to expect that we will have more discussions about complications during pregnancy. I hope you have learned something. Again, you have to fight for this, okay? fight for this. You have to learn more. You have to be committed to your dream of becoming a registered nurse or registered midwife. Thank you for tonight. May God bless you all.